My name is Wendy Profit, and I am your host this evening. Along with me, I have a nice group of friends that I'd like to introduce you to. First, my associate, Haley Catalano, is a program development manager with Endogastric Solutions, spends a lot of time with our doctors in the ORs and sees the good that they're doing with our patients. Also, we're so pleased to have Dr. Keith Goldberg with us from Tennessee, as well as his patient and office scheduler, Tina. So glad to have you both with us. I want to share with you a little bit about Dr. Goldberg. He is board certified by the American Board of Surgery and is a fellow of the American College of Surgeons. He has practice locations in Springfield, Clarksville, and Hendersonville, Tennessee, and has advanced training in general, vascular, and laparoscopic surgery. Dr. Goldberg's clinical interests include robotic and minimally invasive procedures, such as the TIF procedure for reflux. Tina also had the TIF procedure performed right about 21 months ago now, if my math is correct. So we're so pleased to have her again with us. Want to talk a little bit about some food tips for the upcoming summer as folks are considering TIF and or are recovering and are in that that post-operative diet phase that everybody wants to talk about and nobody wants to talk about all at the same time. So stay tuned. Please post your comments in the comments section. Any questions that you have for Dr. Goldberg or Tina, fire away, and we'll go ahead and get started. Welcome, everybody. Dr. Goldberg, thanks again for being with us.
Oh, you're very welcome. Thanks for having me.
My pleasure. So let's talk a little bit about GERD. We have folks who are tuning in and they basically run the gamut from they're experiencing heartburn symptoms. Maybe it's new to them, maybe it's not so new. Some are on medications that may or may not be working right now. Others are in what we call a very active phase who are actively suffering, looking for solutions. So if you could, maybe tell us a little bit about the disease state, what causes it, and what its progression can look like if it's left untreated.
You bet. Happy to do that. GERD, gastroesophageal reflux disease. So basically acid reflux, heartburn, the way people think about that, maybe laying down, maybe at night, starts with some chest pain, that sort of thing. But there's a whole gamut of different symptoms and problems that can arise from it. Most people familiar with, the basic remedies, whether it's Tums, Mylanta, moving on to things like Pepcid and even Prilosec, which is well advertised. And those have been kind of the mainstay of treatment, as well as, of course, watching what you eat, which is hard for all of us to do. But we're really here because there are neglected treatments of acid reflux. And really, acid reflux is not really an acid problem. It's an anatomy problem. And so if I can just kind of stress one thing to people watching right now, is really think it's not so much about the acid, but it's about your anatomy. And there is a problem when acid or stomach contents come back up into your esophagus and cause various symptoms. So that's really the gist of GERD or acid reflux. And if left alone, some of the more common things we see are acid burns or strictures, ulcers in the esophagus, which can scar it down and make it difficult to eat or swallow. You'll hear about people all the time, Wendy, about how many times their esophagus has been stretched, and that's just an awful thing, and it just goes on and on. And so we have methods now where we can really safely, effectively, and with very little side effect, take care of that and solve problems like that. Worse problems, that sort of damage can eventually, in some folks, lead to changes such as Barrett's esophagus, or even esophageal cancer, which is just an awful, awful diagnosis. So that's it in about a 45-second, a minute nutshell.
Gotcha. Thank you very much. Can you talk about some of the typical symptoms that people see that could be indicative of a GERD diagnosis?
Yeah, chest pain, right? I mean, it's something, again, always have to be so careful about chest pain. Anyone with burning pain, that sort of thing, they can be confused with a heart attack or angina and that sort of thing. So chest pain is very common, burning, in the lower chest. But, a lot of patients have different types of symptoms. Some patients don't feel that sort of thing. So they may have hoarse throat, change in their voice, what we call regurgitation or laryngopharyngeal reflux. So bottom line is that liquid can come all the way up without typical burning and actually burn the back of your throat. So we'll get patients from oral surgeons and dental offices with dental erosion wondering how on earth did this happen, and they may be having reflux and not even really realize it.
Wow. All right. How about some of the atypical symptoms?
Yeah, so atypical symptoms, those would be some of those. It would be, really, again, they could have back pain, they could have shoulder pain. They may not sleep well at night. They may not even realize that. There may be snoring involved from the damage to the back of the throat and whatnot. Again, if they don't have the typical chest pain, heartburn, sensation that would be kind of the classic and typical. So again, those things can be difficult. Again, in older patients, that can be, again, the most important thing is make sure you've got the accurate diagnosis, that it is reflux and it's not some other pathology. And so making sure your patients are safe, number one, making sure that, you're not mistakenly treating heartburn or chest pain that is cardiac in origin.
Interesting. So I'm hearing you say that patients may come from, almost all different directions. You may have some folks who go to an emergency room for chest pain that end up in your chair. You may have some folks that maybe go see an ear, nose, and throat doctor. Do you typically receive referrals, or how does that work?
Yeah, I think absolutely. So I get referrals from those folks. So I'll see patients that have been in the emergency room, been in the hospital. Maybe they've been seeing their cardiologist for an unusual chest pain and they've had a dozen different cardiac tests. And the cardiologist tells them, hey, your heart's great. Well, what on earth is this atypical chest pain that I'm having that we thought might be related to my heart? So they'll find me that way. A lot of referrals really are self-referrals. I mean, I would say the vast majority of people know they have heartburn, know they have reflux. So there are just a lot of folks out there that are taking Prilosec for 10 years, 20 years, 30 years, um, and still having breakthrough symptoms. Maybe they're having good results with it, but they don't want to be on a medicine for 50 to 70 years if they're diagnosed early. So those folks will find me and want to get off those medicines and want a more effective treatment. And as Tina can say, because she schedules and she sees post-operative patients through the office as well. We have just found this procedure that combines with some of our traditional robotic and laparoscopic procedures, but we have found TIF, the Esophax Z Plus device, that really just flipped a switch for us. It flipped a switch from us just giving everyone medications and being able to really give them a definitive solution for their anatomy.
Wonderful, wonderful. Tina, maybe you can share with everybody, about what age you started having symptoms. How long did you suffer from GERD before you ended up, being able to have the TIF procedure?
My symptoms started when I was really young. We didn't know what actually caused the symptoms. Me and my sister both had the issues. We got sent to Vanderbilt Children's for testing and everything to try to figure out what was going on, and they still couldn't figure it out. It wasn't until I was probably maybe mid-teens that they were like, okay, well, let's see if maybe it's this reflux thing. And I got put on medicine at that point, and I stayed on medicine from the time I was about 14 or 15 until I had my surgery about 21 months ago.
Wow. Okay. Dr. Goldberg, what is the age group that you typically treat, or is there a set age range for consideration for the TIF procedure?
I would say typically anywhere between 25 and 85 would be the age range. So it's pretty broad. There are exceptions to that. There are, slightly younger patients. Obviously, when you're at the beginning of the curve, I'm going to be more conservative initially. I'm going to really be, looking at the medications, the diet, the lifestyle, is there weight loss that, that would help the patient and that sort of thing, to kind of take pressure off the abdomen and decrease some of that reflux. So are there things that we do in everyone trying to avoid any type of procedure, because it's a, they've got such a long life ahead of them. But the flip of that is, again, if they've been on Prilosec for 5 years and we can prove and confirm that they have acid reflux, I mean, there's not a specific age range. I mean, we're not doing pediatrics necessarily here, but there's no reason that you couldn't do an older adolescent or whatnot in the right situation. I find that some of those older range patients, a lot of times it's not just classic heartburn. Sometimes people have damage so bad, as we discussed earlier, or they have a hiatal hernia that's just so big where their stomach is in their chest that they can't eat, that I'll combine their hiatal hernia surgery with the TIF. And the TIF is really important in all of these procedures, to repair that valve, because just fixing a hiatal hernia, well over 50% of people will still have acid reflux. And I do get that question a lot, or I see that out there, people just wanting their hiatal hernia fixed. And I think in general, that's a mistake. I think that the TIF procedure is just so good and so effective for these people that there's no downside to touching it up. And it's much less invasive. It's much more natural in appearance than some of the older procedures, such as the Nissen fundoplication that, I see on a fairly weekly basis, people coming in with problems and complications from that over the years.
So what options are available for folks like that who come in? What do you typically look at doing to help resolve?
So, again, first thing, meeting the patient, it's really getting that history, finding out, does their history match the diagnosis? Sometimes, patients come in and they think they have acid reflux. And again, you start talking with them and you just discover that it's going to be something else. So accurate diagnosis. And really my minimum workup, other than the history and the physical and our basic get to know you, is really to do an upper scope. Okay, and esophageal gastroduodenoscopy. So take a look, really take my time in there, take a look, take pictures, really look at that anatomy of that lower esophageal sphincter and determine, is there a hiatal hernia? Is there not? Do the endoscopy findings really correlate with their symptoms? And then usually combined with that, I'll get an esophagram, or what's called an upper GI, where basically you're going to get a little contrast to drink, and it's going to create an image of your esophagus. And that's really nice because it shows the pulsation. It really shows kind of the physiology of the esophagus better, how it's moving. Is it contracting properly? Swallowing is incredibly complex. And so that's a nice thing. That'll show some of the anatomy. And sometimes it'll actually demonstrate reflux. So those are kind of just the basic for a classic, I'll call it an easy, straightforward patient, to kind of get them on the right path to determine, okay, again, medications, diet, lifestyle modifications, or is this something that, that we should attack and treat more definitively, depending on their symptoms and their medications.
Okay. So as you're looking at, just trying to go through typical steps to resolve a patient's symptoms before they're moved on to the procedural, therapeutic option. When you're talking about lifestyle, what are the things, that you typically recommend? We talked about weight loss a little bit. Are there certain foods that are conducive to helping resolve symptoms, or something that you want to avoid, either or?
So a lot of that will go in with the history. So, I'll talk with folks about, trigger foods. And so, the basics are this, right? Eat your small, well-balanced, healthy meals 3 times a day, right? Which is hard to do when we're out doing what we need to do. Most people don't follow that basic tenet. the fatty foods, the fried foods, overeating, eating late at night. So, that's a pretty common thing for people if their symptoms are at night, to not eat after 5 or 6 p.m. Now, if you're working third shift in the Electrolux factory, then it's challenging. All of these things are different, and so I try to tailor it to the individual patient's lifestyle. Elevating the head of bed at night, and so we'll usually either recommend a wedge or actually elevating the bed itself. So you're still flat, but your whole body is a little bit elevated, 2 to 3 inches, just to have gravity, but us help you a little bit. But the fact is, people have reflux during the day. I have a lot of people, a lot of folks who are out gardening, doing yard work, and they can't bend over. They go to bend over to do a little digging and regurgitate or whatnot. And so those are people, when they really suffer like that, I mean, it's a tremendous gratification to help them, because they can just really do what they enjoy. Because medicine isn't going to help that. As I said in the beginning, it really is an anatomy problem. But once you reestablish a normal appearing anatomy, then almost all these people can go back to doing really what they enjoy, with no side effects from that.
Excellent. Thank you. Well, I apologize because I had some animation that I wanted to pull up to have you talk us through the TIF procedure. It is not working right now. So I'm going to ask you if you could just explain the procedure as you do to your patients, and help them get a visual. We'll also post a link to the animation for folks before we end the program. Just want to make sure that you can access that as well. But if you could kind of talk us through it, Dr. Goldberg.
You bet. So the TIF, transoral incisionless fundoplication, and it is a special device that during your anesthesia, that I pass through your mouth, go down into the stomach, and then we look back up at your lower esophageal sphincter. And it has 20 sutures. Now, these are sutures just like surgical sutures, same material, but they look, compare them to kind of the fasteners on your jeans when you get a new pair of jeans, and it's got the little H fastener holding your tags on. But this suture is much stronger. I mean, you cannot snap or break this suture. I mean, I have tried, and it's next to impossible. It is a permanent surgical suture, and it is loaded in this device. And it basically, the front end is loaded in, and it passes through your esophagus into the stomach and then flips out. So that end is in your stomach. The other end stays in your esophagus. So you've basically got this H fastener, this suture, one half in your esophagus, one half in your stomach, pinning the edges together. And we do this with a very artistic mechanical rotation and recreating the valve, kind of about a 300-degree valve. And the difference for this, and one of the things I talk about really is compared to the old surgery. The old surgery, or the Nissen fundoplication, is a 360-degree valve. And this 360 degrees, although every surgeon that performs it, including me in the distant past, all says it's perfect and it's loose and it doesn't cause problems, studies show that in the expert hands, there's anywhere from a 20 to 40% risk of complications. And that can be too tight. Patients can't belch, can't vomit, and they end up in the emergency room with this terrible gas bloat syndrome. That's probably one of the worst things with the Nissen. So TIF solves that by doing about a 300-degree wrap. That leaves a little bit of esophagus open. That little bit of esophagus allows stretching so that when you eat, you can eat, things go down well. If you need to belch, etc., you can. And so it's a much more normal physiologic valve. And so we place initially 20 sutures, kind of around the horn, kind of creating this new valve. And then we generally place another 10 to 15 sutures after that, just touching up the areas, making it long, but not compressive. And the beauty of the device is a pretty decent size. It's the size of our typical dilators that we use in the esophagus. So it's literally impossible to make this too tight. It just can't be made too tight because you're doing it over this device. So I hope that provides the picture, but we basically pass the sutures. We take a good look, we wash it out, we touch it up a little bit, and then we're done. And, and again, in contrast to the older procedures, my patients go home the same day. I'll say 98% of patients go home the same day now. And, it's interesting because COVID kind of helped me with that. I was used to the old surgery where people would stay for 2 or 3 days, but during COVID, hospitals weren't allowed to do, at least ours, we weren't doing inpatient surgery for a while. So, I'd have the conversation with my patients. I said, everyone has done great before. I used to just keep them overnight, probably to make me feel better. I'd come up and visit them in the evening and they'd be on their phone or their iPad. I'd just let them go home first thing in the morning. So we just stopped doing that and they all go home that afternoon and people do great. So it's now an outpatient procedure.
That's marvelous. Wow. So you and Haley and I were talking yesterday. Haley, if you'll remember, Dr. Goldberg said, and hey, I oftentimes I find that most of my patients fall into one of, what did he say, 3 categories, kind of 3 examples. Can you share a little bit about that with us, Dr. Goldberg, as far as just a typical patient profile and who is a really good candidate for a TIF procedure?
You bet. Well, we talked about the age range. So I would say, and again, generalizing, but you've got some kind of the younger age patients that just don't want to be on medications, right? They want to live a natural life. They've tried natural things. They're now on Prilosec, but they can't live without it, without suffering. I've had a number of patients who, they can't go out at night. They can't have a glass of wine at night, that sort of thing. And they just don't want to be on a bunch of medications, certainly at 30, 35, 40 years old, et cetera, or even younger. So that's kind of one. It's the people that are doing okay. They're managing with the lifestyle, but they don't really want to. And they'd love to do normal things and not be on medication. Number 2 is kind of the middle road. And that's where, start seeing people that have been on Prilosec for 20, 30 years. Maybe it does pretty well. They've been on multiple different ones. They've seen a bunch of GIs that tell them your last resort is to have any kind of procedure. Honestly, because of the Nissen fundoplication, that's what they're thinking of and dealing with. And when you see those people who had that Nissen fundoplication, yes, there are people walking around that did really well, but you get a handful that aren't. And those GIs remember it because those people are in their practice forever suffering. So you've got those people who are just on medicine, they're not getting good control, but no one wants to give them another option until the next class of patient, which is they've been suffering for so many years. Like we talked about, their hiatal hernia is gigantic. They can't eat anymore. They're losing weight. And so that's kind of that third kind of broad range of the patient where, my gosh, it's at this point, it's a no-brainer. It's a much more challenging operation. The TIF is an absolute part of it, but you have to fix that big hiatal hernia. And so even though it's a harder operation to do and it's a longer operation, when you're doing this and then you're doing the minimally invasive TIF portion with it, those people are still going home. I mean, I just this week did an older gentleman, and I was convinced, he had pulmonary disease. His entire stomach was in his chest, and we're carefully taking that out. The TIF went really well at the end, and I said, well, let's just put this fella in the hospital. He's certainly going to have to stay overnight. Went to see him 3 hours later, and he's like, I'm a little tired, but I feel great, and I'd really like to go home, doc. Go on home, so I canceled his admission. But that's really what's been amazing about just the combination. And the combination is still less invasive than the other procedures because we're just not doing as much surgery down low on the stomach. So the function of the stomach is much better than with the older operations.
So on that note, one question that we get a good bit, and Haley, I'm sure you can attest to this, and you know what, Tina, I wonder if you get this question too sometimes when you are working on scheduling patients, is, if they say, well, look, I guess I have GERD, I guess I have a hiatal hernia, what if I just have one of them fixed? What if I just have the TIF, or what if I just start with the hiatal hernia repair? What are your thoughts on that?
Well, I mean, as far as me goes, and I mentioned earlier that we have data. We have old data comparing, hiatal hernia repair in people that have just had that done versus having the old Nissen even. And we know that 50% of those people that their valve doesn't work. So even though you're fixing the anatomy, and the hiatal hernia is critical to fixing the anatomy, the diaphragm needs to be repaired. That is part of that lower esophageal sphincter. It's the external portion. So we need to fix the hiatal hernia, but that's only half of it. So you have to fix the internal sphincter also. You have to rebuild that with the TIF. So, I just would never recommend that. Do not think that's a good idea. And ultimately, you don't want to come back and have another procedure later if you can predict it and avoid it. And so, I mean, the TIF is the least invasive portion of all of that. And it's just very natural in appearance when you look at it compared to the other surgical types of wraps. Again, it looks like a normal valve. It looks like if you were doing an endoscopy on a 16-year-old healthy patient and you look up at that nice, beautiful valve, that's what this looks like at the end. It does not look distorted. It just looks rejuvenated.
Excellent. It's great to hear. Another question that we get is do folks have the ability to have a hiatal hernia repaired either robotically or laparoscopically? And then also, does that impact the TIF? Is, doing it one way versus the other? Is the TIF still done the same way, or is there a modified approach to that?
Sure. No, there's absolutely no difference. There's absolutely no difference between laparoscopic repair of the hiatal hernia as far as the patient's concerned and robotic. Both the robotic is a laparoscopic procedure. We just use robotic assistance. So it is nice. I think that it is technically, can be more relaxing for your surgeon, which you should care about. It should save our back and allow us to work longer. But you'll have very similar incisions, and so I like the robotic technique. But either way works perfectly well. That's separate from the TIF portion. I mean, as far as the anatomic repair, you have two phases: the laparoscopic or robotic, and then you've got the TIF once you're done with that portion. So either way works perfectly for the TIF. And I would again just urge patients to make sure that their physician that's taking care of them, that is experienced in this, make sure that they identify hiatal hernias, because again, I feel that probably the most likely cause for any type of failure with a TIF, if it's a TIF failure, I think either you've made a wrong decision, it's the wrong patient, or you didn't identify the hiatal hernia. And so if you don't really look and find that hiatal hernia and fix it, I just think that makes everything more successful, and it makes for a happier patient with just great results.
Excellent. Thank you. Tina, your experience.
Yes,
Did you have a hiatal hernia?
I did. Yes, ma'am.
So can you tell us a little bit about how you felt afterward, what your recovery was like?
I mean, really, the hardest part of the recovery was the liquids. It had nothing to do with the actual surgery at all. It was more of just the diet that you have to follow for the 24 hours and then the 2 weeks. It was a little more of a mind game than what I thought it was going to be.
Gotcha. All right. So when you woke up from surgery, did you notice any type of difference in how you felt throughout the day, versus
Oh,
how you
yeah,
felt going in?
absolutely. Within a matter of, I would say once the anesthesia wore off good and I was actually like coming around to be more of myself, like I just noticed automatically that I didn't have that deep burning in the back of my throat that was just always there, that was just kind of uncomfortable. And it was just more of like, not even gonna say irritated. It just kind of like almost like when you had your EGD, you could just feel something was there. And I thought, okay, well, it's coming, it's going. And then by the next day, I was like, they were bringing me my stomach medicine because when I had mine, we were staying overnight. And they were like, here's your stomach medicine. And I'm like, oh, I hadn't even thought about it because I didn't have any reflux, any burning or anything. And that was less than 12 hours later.
Wow. Amazing. Amazing. Haley, I have not checked in on our viewers. How are we looking? Everybody good there?
Great. We do have some really good questions if we want to kind of pivot just a little bit. Is that okay?
I would love to.
Okay. So we have one that is really good, and you've addressed it a little bit, Dr. Goldberg, but it's just, if acid reflux is a mechanical problem, how do my medications work?
So, acid reflux is a mechanical problem, but as you mentioned, so the stomach is full of hydrochloric acid. And so the way they work is by blocking, depending on the medication, but typically the proton pump inhibitors, proton being a hydrogen atom, they block the acid pumps in your stomach. And so therefore, if you have less acid in your stomach, you don't feel the acid reflux. And so it controls, the vast majority of people will have excellent relief, at least initially, with blocking the acid. So that's how it works. It blocks the acid so you don't feel the damage. You don't feel the burning, and therefore it does heal up things like ulcers and esophagitis. And it absolutely is still part of our treatment paradigm. So I don't want anyone to go away thinking there's no role for those medications. We're just talking about, again, people that either want to get off of them, they're not working, they want, something more definitive. So that's how they work. So for example, if someone's symptom is regurgitation or reflux all the way up into the throat, it's less likely that acid suppression is going to solve their problem.
Excellent. Thank you. Okay. Another one is, it's a great question. Hi, Dr. Goldberg. What is dysphagia and why do so many reflux sufferers get it?
Okay, dysphagia. So dysphagia means difficulty swallowing. So fancy name for difficulty swallowing. And it can be, again, lots of different things can cause dysphagia or difficulty swallowing, but specifically with acid reflux, again, that reflux, that liquid coming up into the esophagus will burn the esophagus. It may cause narrowing, what we call a ring or a stricture, where the lining or the mucosa, like the lining in your mouth, gets thickened and fibrotic, and it doesn't stretch the way it's supposed to stretch. And therefore, when you eat or drink, food, liquid may hang up in there. And again, it can be kind of an early formation where you just see a little bit of scarring there, or it can be so tight that you end up in the emergency room, which we do see frequently, because someone just, kept eating through it, and then they went and had a hamburger or a pork chop or a steak, and then we've got to go break that thing up and fish that out, dilate or stretch that area, heal you up with the proton pump inhibitors, get it healthier, get it better, take a look down, and then A, continue those medicines forever because you can't stop, or B, treat the anatomy, rebuild that valve so you don't have the acid reflux, and then you won't need to be on those medications anymore.
Excellent. Okay. And you've done a great job of kind of answering these as we've gone, but another really good one is, how long does the TIF last, and is it something that needs to be redone? I'm 34 on PPIs for 12 years.
Yeah. Well, we have at least 10-year data. Okay. Dr. Testoni out of Italy has published at least 10-year data, and every year there's new data coming out. So we know that it can last at least 10 years. Now, does that mean everyone lasts 10 years? If you look at their overall studies, the original studies with the TIF device, it was approximately started out about 80%. Now, and I'll explain this, 80% of patients in their study were off PPIs and had success immediately. And that lasted through 5 years. Started to see kind of a trend towards 72, 75% at 5 years. But I want to be clear about this because I told you this, I think that the results now are much better than those original studies, which were probably done in about 2007 or even earlier. The reason is, number one, the device has changed dramatically since then. Number two, we're putting a lot more sutures than the original device had. The original device in those studies were about 12 sutures. I told you we're putting anywhere from 20 really up to 40 sutures in some situations. Number three, we're recognizing the hiatal hernia. So as people are paying attention, more patients are getting those hiatal hernias fixed with it. And so, I feel like we're seeing even better results. Now, will it last forever? No, I mean, there are people that have recurrences. Of my some 200 patients, in all disclosure, I have revised one patient. And I just did her. So after 4 years, I revised one patient. It doesn't mean that I had 100% success. I feel like probably, 95%. But, there is an occasional patient, as we talked about, that things just, didn't work perfectly. Nothing's guaranteed in this world. But this one revision, just saw her back. And again, immediately, she was just so happy. So you can touch these things up. It was really easy to revise the TIF. And having not done that, although there are other surgeons around the country that have, I was a little wary of it. But she's thrilled, so I was very happy. So yes, it can be touched up without surgical incisions. The TIF is non-invasive, minimally invasive, so yes, you can touch it up.
And a follow-up to that, I know we had talked about that patient and how well she had done. Is there anything different that you do as a physician, or any steps that the procedure goes through or that the patient will go through for a redo as opposed to the original TIF?
Not for the TIF specifically. And again, I should give a disclaimer. Not that she had COVID, but during the COVID process, she had a horrible cough, and she remembers the moment that her reflux came back. Now, back to that, because of course it's not my fault. But anyway, so what was the question, Haley?
Is anything different about a redo TIF than the original?
No, there is no difference. At least, again, technically, there could potentially be some more adhesions or scar tissue that you don't see outside the stomach.
Sure.
That could limit the mobility of the esophagus and the stomach as you're doing it. But within the stomach itself, you generally shouldn't see any difference.
Okay. Switching it up just a little, we've got a question for Tina. The person asked, did Tina cough a lot before you had your TIF procedure?
I honestly, no, don't never remember. We live in Tennessee, so we have allergies year round, but I don't think that I coughed any less now than I did then.
Anything that is just super obvious to you when you see so many of these patients as Dr. Goldberg that you're like, okay, that's not going to happen after they have the TIF? Or we see this a lot with a lot of our TIF patients or people that come to us that are possible TIF patients?
And I'm sorry?
It was kind of two questions in one. Is there anything that you see pre and post TIF in these patients that is kind of a trend for you?
Yeah.
Like coughing or anything like that?
I think more than I've had a lot of patients that say they cough and it's gotten better. And a lot of my patients know that I have had it. So they'll ask me, have you had anything like that? But I think the most thing that I ever get from anybody is them just being completely tickled to death going, hey, guess what? I'm here for my 2 weeks follow up and I haven't taken a medicine in a week and a half because I keep forgetting it.
Awesome. I love that. Dr. Goldberg, one more for you, and two different people have asked this in different ways, but it is, how long after esophageal ablation can I have the TIF?
That's a good question. That really depends on how the esophagus heals. Okay, so we haven't talked about, we talked briefly about Barrett's esophagus. So for everyone else, esophageal ablation, if someone has Barrett's esophagus, which again, damage from acid reflux causes a change in the cells of the esophagus, the human body is trying to be very smart. So it changes over to a cell that's more similar to gastric or small intestine cells. And a lot of those people don't feel the typical reflux or heartburn symptoms, but those cells can make a mistake in that transition as they're dividing and changing, and that's where we have the concern about that degenerating into what we call dysplasia or ugly abnormal cells that can become cancer. So, with that understanding, esophageal ablation is typically performed through a catheter and basically burning the inner lining of the esophagus. So, burning the lining, causing it to slough off and kind of peeling that inner lining off, allowing the normal cells to heal back in. So that's esophageal ablation. And so the question would be, really, they need to have follow-up endoscopy to make sure that it is healed fully, that there's no residual Barrett's esophagus, preferably at that point, and that the mucosa appears healthy and viable. So it's really probably going to be somewhere like 3 months that I would suggest, that you're probably going to at least wait. But ablation, again, is usually a multiple treatments, unless you just have a little bit of Barrett's. Again, that gets into a whole nother thing. Some people have a little bit of change. Sometimes, unfortunately, you'll find an esophagus where you have, 10 centimeters of esophagus that is just been destroyed and damaged and converted into this abnormal cell. But it's going to be a little while afterwards. Now, sometimes we like to fix the hiatal hernia and do the TIF before your ablation. And the nice thing about that, if you've got a big hiatal hernia, it just restores normal anatomy for the surgeon or GI that's doing the ablation, so they're not trying to oppose their mechanism inside the hiatal hernia. They might not be able to get everything if the anatomy is abnormal. So this can actually help preoperatively or pre-treatment esophageal ablation.
Okay, thank you. Wendy, that's pretty much all we have right now.
Terrific.
We can wait for some more to come in and talk a little bit.
Yep, still have a few more things to cover. Tina, I wanna dig in with you in just a second about the food information that we talked about at the top of the hour. But first, let's talk a little bit, both of you. Dr. Goldberg, we'll start with you. What does life look like for your patients after the TIF procedure?
That's really the most gratifying thing. And I must say, even after this many years doing it, when they come in, I have them come in at 2 weeks. And as Tina said, most of them, even though I tell them they can stay on their medicine those first 2 weeks, just because we've done surgery and procedures and things are healing, a lot of them forget to take the medicine. They tell me that immediately, and I tell them this too. The very first night that they have their procedure and they lay down flat, they will not have reflux. They will no longer have reflux. And so it is immediate. And people notice this. They notice it very quickly. And again, a lot of times the more severe their symptoms were, the more they recognize that. The more recognize that they weren't able to bend over, they weren't able to lift heavy things. And they weren't able to do their normal activities. By the time this is all done, they could do it all. So, people really, there's a lot of people that it's life changing for those different categories of patients. Of course, the patients that had the TIF and the giant hiatal hernia, those people can eat again. Now we do have them on that liquid diet initially, so technically they don't eat again, they drink again. But by 2 weeks, they're on a pretty regular soft diet. And so they're eating again pretty quickly, given the years that they've been suffering.
Excellent. So Tina, when you are talking with patients, first we're gonna talk about the things that y'all talk about when you're counseling them, just as far as the diet goes, what the recommendations are afterwards, versus what you did. Can you kind of walk through what you outlined for them, kind of week by week, and then what some of the life hacks are? What are some of your expert tips that you can offer up?
Yeah, so like the first 24 hours, they're going to be on clear liquids only. After that, we tell them that you can go to a liquid diet. So you're going to need to be able to pour it from one cup to another with no solid pieces or anything in it. Whether that be broth or, if you have I have one patient who said she had potato soup and she put it in the blender and she blended it up. And I was like, that wasn't too thick because this was just a couple days afterwards. And she was like, no, it was great. We have to remind them to eat frequently, but eat very small amounts and gradually increase that amount. Because if you eat too much, you are going to know. I'll tell you from experience, I thought I was starving and I started drinking and it was too much. And like it hits your stomach hard and you're like, whoa, yeah, that was definitely too much. But I tell my patients, during that 2 weeks, your hardest problem is it's going to be a mind game because you're going to get so tired of liquids that you're not going to want to see another liquid ever you feel like. So I tell everybody, go on Pinterest, create you a board, put all kinds of recipes that look good in it. Start out weeks before you even plan on having your procedure. And when you think you have more, go grab you about 15, 20 more recipes, because if you're like me, you get tired of eating the same things. And I thought, oh, I'm great. I've got like 6 or 7 recipes. But then when you go talking about eating every 2 to 3 hours and you have those 6 to 7 recipes, that's the biggest struggle. And that's the part that really became the mind game.
What a great idea. The Pinterest board. I love that. Technology. So what were your go-tos that you remember in the first 2 weeks? And then what were the things that you really looked forward to that you savored the minute you could have them?
I did a lot of the broth, like just straight broth, due to some gluten allergies and stuff. I wasn't able to eat a lot of the thicker, creamier based stuff that other people are able to eat. And to be honest, I was just making any of that time. So I did do a lot of the like broth based soups. I did like butternut squash soups, cauliflower soups, different things like that blended up. And then at that point, by that time, I kind of got tired of eating soups all the time, and I started doing the protein shakes because I could change those up a little bit and have a little bit more flavoring versus these big batch of soups that I had prepared and didn't do enough planning for it.
Gotcha. Very good. Okay. What was your first big, I'm going to reward myself. I'm at the right time, and this is what I've really been looking forward to?
A piece of grilled chicken.
Really?
That was like the best piece of chicken I think I had ever eaten in my life. I would think about chicken because I could live off chicken. I kept thinking, I want chicken, I want chicken, I want chicken. And the moment that I finally got to eat a piece of grilled chicken, I was like the happiest girl on the planet.
That's great. Golly, we hear pizza, we hear burritos. I haven't heard grilled chicken before.
Yes.
Wow. Terrific. Well, Dr. Goldberg, we didn't really cover this, but I, feel we absolutely must. The reason that you were drawn to TIF is due to a person who's very close to you. What were the things that she looked forward to having, and what did she nurse on the first couple of weeks?
Well, so referring to my wife, who really was one of the motivations early, really suffered in reflux and was on PPIs for over 20 years, and they just weren't cutting it. We'd even taken her to the emergency room. Now I forced her to go to make sure she wasn't having a heart attack. She was not happy with me. She wasn't. She was fine, but it was that severe. She would have just terrible heartburn. She'd be sitting up in the middle of the night, and and then I'd wake up and see her sitting bolt upright. So she had really severe symptoms. And so when she had the procedure done, and this was, I don't know, 3-4 years ago, maybe more than that. Maybe it was 5 years ago now, I think, that she had that done. She worked with soups. We found she liked Chobani drinkable yogurts. Not to plug Chobani, but but it could be generic. Any yogurt's fine. But she liked the flavors, so she really got tired of plain flavor, as Tina alluded to. So having different flavors, the mango or the strawberry and that sort of thing, that helped her. She found that consistency kind of soothed her esophagus in the first couple days. Patients do get some spasm of the esophagus initially. They get some shoulder blade pain kind of referred pain from the diaphragm and the esophagus to the back for the first couple days. And so that really, she liked that more than broth or clear liquids. She liked the full liquids. What did she want? She's a foodie. She loves to eat. So, she wanted a hamburger. Again, I won't plug any specific hamburgers, but she wanted a burger bad. And my daughter really controlled her and kept her in line. She was home at the time, and I don't know that my wife would have had the willpower not to cheat had she not been there as the liquid and soft diet food police for her. So having someone that can encourage you and be there and remind you why you did this, and to just be a little bit patient as far as the diet goes. But now she's eating everything. But I think that was a big one. I've definitely had people that want pizza. I have had people cheat. On occasion, someone will say, yeah, that first week I had a French fry. That wasn't the best idea. And so, we do a lot of education up front, between me, Tina, we've got written protocols for patients that we've adapted over the years, to really try to help them prepare and understand what they're going to be going through, so they have their eyes wide open for the procedure.
Excellent. Well, so we've got the first 2 weeks are pretty much, liquid, pour cup to cup. Is that how do things progress afterwards? And how long is it typically before a patient gets back to their normal diet or their new modified diet?
So, I told them for 2 weeks, I say, start out, as Tina was saying, frequently, stay hydrated, about 5 ounces, 5 to 6 ounces at a time, nice and easy. So you're just not straining that esophagus. You're not filling it up, and you're not stressing the valve, letting things heal. And every hour to two, really. I mean, whenever they're thirsty, whenever they'd like, they of course can have clear liquids, but I do like them to have something with calories in it. Patients do lose a little weight. Now, most patients like that. Again, I tell them it's not a weight loss procedure, but I definitely have some people that have kept the weight off after doing it, because once you go through this kind of 6-week diet, there's some people that their brain has transitioned and they don't need that big meal anymore. So 2 weeks though, full liquids, kind of 4 to 6 ounces at a time. Frequently stay hydrated, make sure you're urinating and that sort of thing. Around 2 weeks, sometimes a little earlier, sometimes day 12 or so, they can transition to soft foods. So any kind of egg, well-cooked pastas, I ask them to still cut them up, fine. And again, still kind of go with the small amounts frequently. I let them have mushy tuna fish and chicken salad. I used to hold that out as a surprise for them because they don't think they can have any meat for 6 weeks. But if it's nice and moist with a low-fat mayo or whatnot, and I let them put that on a Townhouse or a Ritz cracker. And the reason being, if they nibble that's going to be soft by the time, they're swallowing that. And so that gives them bread. And that leads us to kind of that 6-week period. I tell them no steak, no ribs, no chicken, no pork chop, no sandwiches. And so really it's kind of no bread, no firm meats for 6 weeks. But again, in that soft kind of 4-week period in the middle, they can have spaghetti with meat sauce for all I care, as long as it's not chunks. And they can have tomato sauce if they want, because they're not going to have heartburn anymore. And so they can have a lot of different things, and it's all fish, of course. But I think it gives them a pretty wide variety of different types of foods they can have.
Excellent. I haven't heard the tuna or the chicken salad. That's brilliant. And the cracker. Oh my goodness.
I know. I kept it as a secret for a long time, and I surprised patients with it at 2 weeks because they're thinking, I'm not going to have any meat. I'm not going to have any bread. And those are just really great cheats that I don't think any of my patients have had problems with. And it really gets them to that meat and bread period earlier. Just again, one of those little life hacks for them, and I think it makes them pretty happy. So I usually tell them at the 2-week period, because I don't want to confuse people in those first 2 weeks. I just want you to remember the full liquids for the 2 weeks. We're going to be seeing you back. We'll move on from there. But we do give them some preemptive instructions.
Excellent. Thank you. Well, before we wrap up, Haley, I just want to jump back to you and make sure we do a check-in on viewers and see if there's anything else that you have to add.
Yes, just a couple more. Someone asked where Dr. Goldberg's located. So, Dr. Goldberg, do you want to just speak to the multiple cities that you kind of offer this procedure?
Yeah, we have 3 offices where we do consultations. So we're in Middle Tennessee. So we're in the Nashville area, and our practice offices are all just north of Nashville. So Hendersonville, Tennessee, Springfield, Tennessee, and then we have my nurse practitioner out in Clarksville, Tennessee right now who can do all the consultations. Of course, I do all of the endoscopies, I do all the procedures, and I like to talk to patients, meet them and see them, and I go through all of this with you. So I prefer to see you personally, but for convenience in the Clarksville area, she does a fantastic job. And so we have a number of patients that come from Clarksville. Yeah, our other offices are 30 to 45 minutes apart. And so they may not want to take that drive in their follow-up sometimes. And so Jessica up in Clarksville will take great care of them up there. And quite honestly, they love her. And so they're happy to continue their care with her. They see her beforehand, they see her afterwards. But yeah, the Nashville area, just right outside of Nashville.
Excellent.
Easy drawn to go to CMA Fest down there this week. If you come visit me and then go misbehave at CMA Fest.
There you go. Okay, one more that I just have to ask because I'm curious to see how you'll answer this, but it's kind of anecdotal. It says, I had GERD and suffered for years. My dad told me to just drink water when it happens, and it works. I haven't had to take meds in 15 years. Drink a glass of water or sip or two. Does that really work?
Yeah, I mean, listen, I think that makes perfect sense. I mean, that's very reasonable. Basically, when you swallow, we talked about how dysphagia earlier.
Mm-hmm.
We talked about the complexity of swallowing, and I tell my patients, I don't know how we swallow. It's an amazing feat that everything coordinates perfectly. But the bottom line is, when you drink, that starts that coordination, that starts peristalsis in your esophagus. So if acid or reflux is trying to come up, drinking anything or even eating can potentially help increase peristalsis to push it back down. So yeah, it's a great life hack.
Good to know. Okay. Wendy, that's all we got. They did such a great job of addressing them as we went.
Well, wonderful questions tonight. So we appreciate our viewers and appreciate the answers from our esteemed panel. Want to go ahead and just let everybody know, number one, if you are looking for a TIF expert in the area where you live, you can go ahead and access our physician directory, our locator at gerdhelp.com. You can simply punch in your zip code and find providers that are in your area. You can certainly find everybody in the US by just zooming in or out on the map. So you'll even be able to find Dr. Goldberg no matter where you are. We also have an app that is the first of its kind in the GERD space, where it is patient education that you will have at your fingertips. It is customized for you so that you can go ahead and start journaling your symptoms. You can also see videos. You can learn about GERD through various articles, etc., and help you have a higher quality visit with your physician once you're ready to see somebody about your symptoms. It's a great help to your doctor because they can go ahead and start the workup process. It provides real-time information for them when you are experiencing your symptoms and helps them determine, just the best pathway for you treatment-wise, whether that is a specific type of diagnostic test to really pinpoint what you are suffering from, or whether that is just giving you more information so that you're equipped with more questions to ask your doctor when you see them. You can also access that at gerdhelp.com. You can go over to the section that says Get the App, and it will take you to your app store, whether that is for iOS or the Android platforms. Dr. Goldberg and Tina and Haley, thank you so much. Y'all, it was Haley's debut this evening. Terrific job from the support desk. Thank you very much for being here. And we hope to see everybody back next week for our TIF Talk. We appreciate you being with us. and have a great evening.